So we were discussing how to differentiate between tension pneumothorax and simple pneumothorax on chest X-ray. First of all, how to diagnose or identify a pneumothorax on chest X-ray. Then we'll discuss what is the difference between tension and simple pneumothorax. So you can see in this X-ray that this lung is jet black and there are no lung marking present on this side of chest X-ray. And you can see a boundary, clear boundary between this black area and this white area. So this boundary is of the pleural edge, and this all black area is basically air that is present in the pleural cavity. And due to presence of this air, the pleural edge or the lung is kind of collapsed into a smaller position, and you can see the boundary between these two areas. Similarly, you can see in this diagram as well that this is jet black area, which is representing air in the pleural cavity, and you can see a white area here. This one, this is the collapsed lung, and there's a boundary between these two. So jet black lung, jet black chest X-ray, and a visible pleural boundary or pleural edge will make the diagnosis of a pneumothorax. Now, a tension pneumothorax and a simple pneumothorax. In tension pneumothorax, you can see that trachea is deviated towards the opposite side, or mediastinal, there is mediastinal shift is present. Mediastinum is shifted towards this is trachea, and this mediastinum that should be present here, it is shifted towards the opposite side, towards the right side. So this is a tension pneumothorax, and here you can see that trachea and mediastinum is central. So this is a simple pneumothorax. And another difference is that in simple pneumothorax, hemidiaphragms are at equal heights. Hemidiaphragm, this one, this is one hemidiaphragm, and this is second hemidiaphragm. Both of them, they are at equal height. While in case of tension pneumothorax, the hemidiaphragm, due to excessive air, compressing air in the pleural cavity, the hemidiaphragm is depressed. This hemidiaphragm is elevated, and this hemidiaphragm that is on the affected side is depressed below than this one. So tracheal or mediastinal shift towards the opposite side and depressed hemidiaphragm. These are the 2 points on the basis of which you can differentiate between non-tension pneumothorax and a tension pneumothorax. Is it clear, everyone?
So in the tension pneumothorax, if it is depressed, the pneumothorax, so what is the reason? It's because it's giving a compression on the area.
Because there's excessive air in the pleural cavity, entering in the pleural cavity, which is leading to, you can say that, hyperinflation of the pleural cavity. So that's why this hemidiaphragm is depressed due to tension in the pleural cavity.
So the air will be trapped in there, so it will compress that hemidiaphragm.
Yes. In tension pneumothorax, there is a compressing rim of air, which is compressing the lungs and everything.
Right.
So this compressing rim of air basically compress the hemidiaphragm.
Right.
Put pressure on the diaphragm. That's why hemidiaphragm or diaphragm will be depressed on the affected side due to
Okay.
high pressure.
Thank you.
So now some points about the management of uh, primary spontaneous pneumothorax and secondary spontaneous pneumothorax. Before we discuss the management of primary spontaneous pneumothorax and secondary spontaneous pneumothorax, can somebody please repeat the management of tension pneumothorax in a stepwise manner?
First, high flow oxygen. Then there should be needle decompression. Second, intercostal space meets clavicular line. Then, when patient is less distressed, we'll put a chest drain tube at the fourth intercostal space that meets axillary line. And then we'll confirm the position with chest X-ray.
Yes, these are the 4 steps that we'll do if the patient has a high clinical suspicion of tension pneumothorax and he is hemodynamically unstable or hemodynamically compromised. And if the patient is stable and his oxygen saturation is normal, then the first thing that we'll do is to do a chest X-ray to confirm the diagnosis first. So now some points about primary spontaneous pneumothorax management and secondary spontaneous pneumothorax management. Primary spontaneous pneumothorax, if the rim of air is 2 centimeter or less than 2 centimeter, then we will only give supplementary oxygen. And if the rim of oxygen, air is more than 2 centimeter or the patient is distressed, then we'll aspirate the air with the needle. So simple. In primary spontaneous pneumothorax, if the rim of air is 2 centimeter or less than 2 centimeter, then I will give only supplementary oxygen. Conservative management will be done. And if the rim of air is more than 2 centimeter or if the patient is distressed, then we will aspirate it with a needle. Now, what about secondary spontaneous pneumothorax? In primary spontaneous pneumothorax, 2 centimeter was managed conservatively, while in secondary spontaneous pneumothorax, 2 centimeter rim will be managed with aspiration with the needle and not conservative management in case of secondary spontaneous pneumothorax. And if the rim of air is more than 2 centimeter, then we'll put a chest drain. While in case of primary spontaneous pneumothorax for a 2 centimeter, more than 2 centimeter rim of air was managed with needle aspiration. So in secondary spontaneous pneumothorax, a more than 2 centimeter rim of air is managed with chest drain. Remember this difference. So this was all about the management of primary and secondary spontaneous pneumothorax. Let me show you a flow diagram to make things a little more clear. So this is an important flow chart. Primary spontaneous pneumothorax, patient is short of breath or the rim of air is 2 centimeter. Two criteria for needle aspiration, that is either the patient is short of breath or the rim of air is more than 2 centimeter on chest X-ray. Then we'll do needle aspiration. And if needle aspiration is successful, then we'll consider discharging the patient. And if needle aspiration is not successful, then we'll repeat the needle aspiration. And if again the second needle aspiration is also not successful, then we'll put a chest drain in primary spontaneous pneumothorax as well. So again, patient is short of breath or rim of air is more than 2 centimeter. If yes, then we'll proceed for needle aspiration. If no, we'll discharge the patient by giving supplementary oxygen only for some time. So needle aspiration, first attempt. If failed, then we will do the second attempt. And if still patient is short of breath and air is not removed, then we'll put a chest drain. Now, secondary pneumothorax or secondary spontaneous pneumothorax, shortness of breath and rim of air is more than 2 centimeter on chest X-ray. If yes, we'll put a chest drain. Otherwise, we'll do a needle aspiration. If no, we'll do needle aspiration. And after doing a needle aspiration, we'll admit the patient for 24 hours to observe the patient if he develop further shortness of breath or not. So another difference you can note in this flow diagram is that in secondary pneumothorax, secondary spontaneous pneumothorax, after needle aspiration, we admit the patient for 24 hours for observation. While in case of primary pneumothorax, after needle aspiration, we will think about discharging the patient. Is this diagram clear, everyone?
Doctor, regarding primary spontaneous pneumothorax, so if more than 2 centimeter or shortness of breath, so we'll do needle aspiration, then we'll again repeat. If not successful, then we'll put chest drain, right?
Yes.
Secondary pneumothorax also, like if more than 2 centimeter, chest drain unsuccessful, then we'll admit for 24 hours.
Yes, if the rim of air is more than 2 centimeter, then we'll put a chest drain. If it's less than 2 centimeter, then we'll do needle aspiration.
That's
And
why
if needle aspiration is successful, then we will admit the patient to observe the patient.
Okay, so if needle aspiration successful, we'll admit. But with
Yes,
chest drain?
With chest drain is definitely admission. That is for chest drain, we definitely need to admit the patient.
Okay, okay.
So then we'll remove the chest drain. If needle aspiration is successful, we will admit the patient for 24 hours to see if the patient further develop any pneumothorax. And if he does not develop any pneumothorax, then he can be just discharged after 24 hours. While if needle aspiration is unsuccessful, remember that in primary spontaneous pneumothorax, we'll attempt 2 needle aspiration. And if they are unsuccessful, we'll put the chest drain. In secondary spontaneous pneumothorax, if the rim of air is less than 2 centimeter, I will do needle aspiration. And if it's unsuccessful, then we'll put a chest drain. And we can discharge the patient after putting the chest drain, because uh, chest drain can be managed at home. We will only remove the chest drain if there is no bubbling of air in underwater sea for 24 hours. So this is the criteria to remove the chest drain after pneumothorax. So a man with the COPD and 1 centimeter.
Can you repeat when can we remove the chest drain? You said something about
Yes, the chest drain
no
can be removed
bubbling
if
of
there is
water. I
no
didn't get that.
no bubbling in underwater seal for 24 hours.
What does that mean?
Chest drain, when we put the chest tube, usually there is an underwater seal, a bottle that contains 300 ml of water. So the bubbling in the water means the air is still present in the pleural cavity. When there is no bubbling, it means all the air has been removed. So that's why when there is no bubbling in the underwater seal, the bottle that contains the water, in which one end of chest drain is put, so it means there is no air left in the pleural cavity. So we'll remove the chest tube.
Okay, thank you.
Chest tube basically has 2 parts. One is a tube, and the other one is a bottle that is known as underwater seal, which contain 300 300 ml of water so that a positive pressure can be created.
So doctor, needle aspiration after will admit to observe for 24 hours if there is recurrent pneumothorax. And after chest drain, we'll observe for 24 hours, and unless there is no like bubble, then I will discharge, right?
For chest drain, we can discharge the patient, and we can guide him that if there is a, he will need a follow-up of this patient. So we'll call him after 24 hours and we'll ask him if there was any bubbling. So he will tell us that there was no bubbling since this many hours or since this many hours. So then we can decide about removing the chest drain. So in short, you can say that a patient can be discharged after putting the chest drain, and then they can be followed on outdoor basis. While after needle aspiration, we need to admit the patient because we haven't put any chest drain. And if the patient again develop pneumothorax, then we'll think of putting a chest drain to that patient. That's why if needle aspiration is successful, we need to admit the patient for 24 hours so that if we can observe him if he develops more pneumothorax. So let's do this question and it will make things a little more clear. A man with COPD and 1 centimeter pneumothorax presents to emergency department. What is the most appropriate management?
Needle aspiration.
Needle aspiration and just needle aspiration. Yes, needle aspiration and admission. Needle aspiration and admission. That's right. So secondary spontaneous pneumothorax, less than 2 centimeter size, needle aspiration and admission is the most appropriate management. Remember that tension, I have told you 3 reasons, 3 causes of tension pneumothorax. That is, it can be caused by car accident, it can be caused by stab wound, it can be as a complication of CT guided lung biopsy. Now, a fourth condition that is also very important, a fourth cause of tension pneumothorax is that it is a serious complication that is associated with positive pressure mechanical ventilation. So if a person is on ventilator and he suddenly deteriorate and become hypotensive and his neck vein become distended, so we'll think about tension pneumothorax because tension pneumothorax is a serious complication that is associated with positive pressure mechanical ventilation. So remember this fourth cause as well for Plab 1 exam, because sometimes they will ask that a patient is on positive pressure ventilation and suddenly he become short of breath, hypotensive, and his neck veins are distended. You will suspect tension pneumothorax in this case as well. So this was all about pneumothorax, different types of pneumothorax and their management. I hope it's clear to everyone.